and Sterile Endoscopes, a new series from Beyond Clean, where we dive into the seismic shifts redefining endoscope reprocessing today. It's hosted by me, Hank Balch. In this series, we'll unpack groundbreaking innovations, sterilization standards, and best practices transforming patient safety in real time. With insights from industry experts and frontline champions, we're here to help you navigate the complexities of endoscope reprocessing and sterility. This series is proudly sponsored by ASP, Advanced Sterilization Products, protecting patients during their most critical moments. And now, sit back and stay tuned for an eye-opening journey into the future of endoscope safety. All right, Sterile Processing Universe, my name is Hank Balch. Thank you for joining us for this episode of our 6-part series, Safe and Sterile Endoscope, sponsored by ASP. And today we're talking about endoscope design and functionality in the context of reprocessing. We're going inside this idea of innovation in this space. There's so much going on. You're going to hear that in the series itself. We're going to give you a little bit of background about how we got to where we are today. We're going to talk about some emergence of different technologies, some different material science that's impacted it, this endoscopy space, particularly with devices and reprocessing, obviously. And to do that, we've got some all-star guests in studio with us today for the podcast that I guess right now is probably the best time as any to go around and do some introductions. So let's maybe first start here with Tamara. Tamara Beehler, you were telling us before we started recording here, your background as an endoscopy nurse. You've got your MSN, your RN, and your current title at ASP is Senior Clinical Education Consultant. That's all the bio piece, but tell us a little bit about your background.
Okay, thanks, Hank, for having us on here. We greatly appreciate it. As you said, I am a GI nurse by trade. I always will be, and love the GI space. I've been in that since 1995. I do live in North Carolina, and that's where I've spent all of my nursing career, but with ASP traveling across the country to share my knowledge and to educate customers. I come full circle through ASP, moving from the sales side and corporate account side back into clinical. So coming back home and happy to be in this space, especially with all the innovation we've got going on right now.
Yeah, it's a really fun time to be in it. It's a lot of fun, obviously, be talking from the educational side as well. So yeah, really looking forward to tapping into your experience today through the interview. Let's go next to Khoi Pham. He is the Senior Scientist, R&D, Technical Business Solutions at ASP. And we're going to be talking about a lot of technical stuff, a lot of science stuff with you here today. But yeah, what's your background, Khoi?
Yeah, so I've been with ASP for about 19 years now. Technical business solutions here at ASP encompasses high-level disinfection and terminal sterilization. So I've worked in both groups here at ASP, so I have an understanding of SteriRad, Evotech, I think what we'll be talking about today. I've had a hand in at some point through my 19 years here at ASP.
Yeah. So, 19 years is a long time, but then it's kind of not a long time when you think about how much stuff has happened in just a short amount of time, right? Like 20 years. It used to seem like that was a long time, but man, the older I get, the shorter that is. So, to your point, Khoi, maybe let's start there.
Sure.
When we say design, there's a lot of different things we can mean. We can mean department designs. We can even mean, in some sense, curriculum education designs. We can obviously mean device designs. And then we can mean equipment that's reprocessing these devices. But maybe let's start at that endoscope design piece. How does that impact everything else that we're building around this device then to effectively, efficiently, consistently reprocess the device correctly? Where's that complexity coming from?
Right. Well, the complexity starts with just the device itself, right? When I started here at ASP, I was in charge of actually doing the cleaning claim for Evotech. So being able to clean endoscopes in a way that was equivalent to a nurse or someone in SPD reprocessing these endoscopes. I was actually trained with SG&A to do scope reprocessing, and I just know how difficult it is to reprocess scopes, how many steps there are. So the fact that, our AERs are able to mimic that in a consistent way, I think is so important to people out there in the field.
I know a lot of endoscopy technicians and nurses, to your point, we kind of scream from the trenches. We're like, hey, this device is complex. It's hard to reprocess. But, to your point, you're on the other side. Like, you got this device and now you're building solutions to reprocess it correctly. And so you're confronting the same challenge that clinicians are. But you're seeking to solve it, from a technological innovation perspective. How do you approach that? And then, from that science perspective of now I can overcome the complexity, like really any way that you want or any way that you can, through these designs. Like, what kind of roadmap or decision tree are you following to say, okay, this is what we want to build to make this happen?
Right. We know all the steps that we need to follow for manual cleaning. So taking those into mind and automating those steps, I think, is very important for us. It takes away the human error that's involved with manual cleaning. If someone forgets a certain step, forgets to do a leak check or something like that, or enough flow of high-level disinfectant through a channel, those are the kind of things that we're hoping to eliminate the human error involved with manual reprocessing. And I think that's why AERs are such an important part of SPD.
And Hank, as Khoi said, we can design something to automate and to do the reprocessing for you. We rely solely on our MDM partners for the scope design. So when we partner with them, they say, okay, I've got the scope, you've got the reprocessor or the sterilizer. What types of changes need to happen so that it doesn't degrade that device as it goes through each of those cycles? And that's really the important part that ASP plays with our MDMs, is to make sure if the end customer, the gastroenterologist, say, I need this device and now I want it sterile. Okay, ASP, what do we need to change on our part to make it feasible to go through those cycles? So that's where we play hand in hand with R&D to R&D, from medical device and the functionality with the sterilizer.
Yeah. And to add to that, we are working with a lot of MDMs with prototypes that they're creating for, new endoscopes, making sure that it is compatible with STERRAD. If you go onto the STERRAD Sterility Guide right now on STERRADSterilityGuide.com, there are a bunch of bronchoscopes, ureteroscopes, and cystoscopes that are on there that we have tested with STERRAD to make sure that they are compatible as they are prototyping and creating new endoscopes. They do work with us. It is like an R&D to R&D. We are helping them make sure that their endoscopes are functional after repeated reprocessing, and also that the efficacy is there as well. So
that seems like common sense, right? That you guys would be working together, and yet it's a lot more complicated than just, hey, like we make scopes and hey, you guys make equipment. There's a lot of balance that goes into, like you mentioned, prototypes, right? It's always this chicken or the egg scenario of, well, do we build the equipment to reprocess something that's not come to market yet? Or, do we wait until it comes to market, but it can't come to market unless there's a process that can effectively process it. So all these balances and intersections are coming together. So yeah, that background collaboration is absolutely critical to make sure that we don't get in scenarios where we have been in the past in the industry where we feel like there's no good solution to effectively or consistently process this. And that's where we end up in all the gray areas compliance-wise. So you mentioned, Khoi, maybe this is the time to bring this up. You mentioned that material compatibility guide. I think it's really, really important. In the industry, like we know that there's all kinds of innovations happening. Like there's robotics, there's more automation coming on, but there's innovations in materials themselves. Can you speak to like maybe what some shifts that you're seeing on that material science piece and how that's impacting these?
Yeah, so one thing I can bring up specifically, and I'm sure maybe many of the listeners know, a common lubricant that's used in endoscopes is molybdenum disulfide, very commonly used. But if that lubricant comes in contact with the hydrogen peroxide, the the oxidization of sulfur occurs and creates sulfuric acid. And that can, further degrade the endoscope it's eating the endoscope from inside out, right? So it's not just materials, it's lubricants, it's all those kind of things, adhesives as well. So endoscope MDMs are finding alternatives, finding different grades of, let's say, materials, different grades of lubricants and adhesives to use. So it's not uncommon for them to send us prototypes with different adhesives, different lubricants, and different materials to test out. If it does well, then they can proceed with that. If not, they'll just have to find an alternative.
Yeah. And Hank, something that's really important to note here is our audience may not know how long it takes for that process to happen. 2015 is when CRE had the big outbreak and was so popular with negative outcomes. And that's when the discussion started about how do we move from HLD to increase that margin of safety to sterilization. And it's taken this long to get somewhere. And, the scope manufacturers, I can't speak for them, but they could have already been in process of trying to do that. So it does take a long time. It's not like I need it today and I'm going to get it tomorrow. It is years of science and research and development on both sides of the sterilizer as well as the device.
Yeah, those outbreaks definitely get the ball rolling a little faster sometimes. But to your point, there's a process that has to be followed, that no one wants to rush the solution to market if they can't depend on all the things we just talked about with the material compatibility. But then also, Tamara, I guess my question to you is, there's other competing, factors here. So there's like the diagnostic capabilities, there's the therapeutic capabilities of the scopes themselves that now we're also balancing with the reprocessing side. So they got to work in the GI suite the way that the physician needs it. But then once they come back to reprocessing department, we got to be able to adequately clean it and disinfect it. And then in these cases, also sterilize it. So how do we balance those? Like, where do we navigate in this complexity here?
And you hit the nail on the head. It's one more step in the complex procedure that we are making changes to. And when you think about diagnostic versus therapeutic, we have different scopes for that. We have a diagnostic scope, therapeutic scope, and those channels are different sizes. We don't need large working channels when we're just going in to look for diagnostic opportunities there. But when we move into therapeutic, where we're going to be doing interventions, we need larger, multiple working channels so that we can, take care of that patient in whatever situation scenario it is in a faster way. But when you look at that, it's not one size fits all when you look at the cleaning piece of it. You've got different size brushes for even different scopes for the buttons, each channel, for now the distal tips, especially on the duodenoscopes that are disposable. But how do you clean that actual distal tip of that duodenoscope that doesn't have, the disposable piece on it? So when we think about all of that, it's so many different pieces. And now you're bringing more manufacturers into the picture to make sure that the brushes are appropriately sized and that we can clean those, because as we know in the cleaning world, the smaller the channel, the harder it is to flush through, which gives you higher pressures. You've got to make sure that you're not damaging the scope and things like that, especially as you're flushing those smaller channels versus the larger channels that flow a lot easier. So it does make a difference and makes it even more challenging.
So, Tamara, you mentioned the CRE outbreak of 2015 and how like that kind of gave a little bit more momentum to many of these conversations. But it seems like from the outside looking in that a lot of the solutions, obviously early on, were focused on those larger diameter scopes. And those are the ones that if we're going to be able to move those to sterilization, those are the ones that we're going to be moving. We're going to be innovating processes to do. But now we're finally starting to see more research and everything coming out of, hey, yeah, there's risk in these larger diameter scopes, but there's also risk in the smaller diameter scopes. And we got the same patients, many times getting both of these types of scopes used on them. Has it just been because that's where the press kind of focus was, or were there other factors that kind of made the industry prioritize one versus the other?
No, I think when we look at the lumen size and length claims that we've had in the low temp sterilization market for our gas plasma technology for STERRAD over the years, the smaller diameter scope, the bronchoscopes, the cystoscopes, laryngoscopes, ENT scopes, things like that, those lumen lengths fell into that category that was already capable of processing lumens in single lumen scopes. We just had to work with those MDMs to make sure that they were functionable after the cycles. So years ago, we had this little half moon symbol that was added to some of the devices so that the technicians would know, hey, this scope can be sterilized in the STERRAD versus just high level disinfection. And as we know over the years, we've had the Urology Society as well as people that are pushing from the pulmonology side. That's kind of a gray area. Does it fall under SG&A from a GI perspective, or does it fall under, another organization to follow from the respiratory side? So when I was a GI nurse manager, we did do bronchoscopes in our department. And we had to move into other areas to do them because we needed those positive and negative pressure differences for those procedures. So it does make it more challenging. So then that's where the discussion is, what department does it fall under? And then who's reprocessing? Is it going to GI? Is it going down to SPD? So just making sure that all the departments know what's coming to them so that they have the proper tools that they need and disposable brushes and things like that to use. But we've almost moved away from diagnostic procedures when we get into the ERCP discussion. As we know, when we go in to do ERCPs, it's about 99 to 100%. We're going to be doing something therapeutic. We just don't warrant having the need to do an ERCP for just a diagnostic reason. There are radiology procedures that can look at that. So definitely diagnostic is moving away from that. But then in the GI world of EGDs and colons every day, we see diagnostic all day long when we're looking for screening. So definitely more to come on the horizon. But we're starting with, I think, as you said, what's most important and most critical to increase that margin of safety. And right now it's looking at the duodenoscopes.
Yeah, I think you brought up a really interesting trend there around these facilities trying to determine the scope reprocessing volume and workflow. What departments is that going to go to? And as we continue to build out and grow, are we investing in multiple different reprocessing areas within the facility? Or are we trying to centralize that under one kind of department housing? And there's a lot of implications to that. I don't think there's one like right or wrong answer there, but folks definitely need to be thinking as they're investing in equipment for reprocessing, as they're investing in training and staffing and all that stuff, because it impacts the bottom line of quality, safety, consistency across the board. I want to go back, Khoi, to something that you mentioned, but also like Tamara kind of alluded to it here. In the decision-making process from high-level disinfecting scopes to maybe changing to sterilize your scopes, one of the most common concerns, maybe not so much from the GI perspective, but it might be there as well, but I know from the sterile processing angle, it's assumption that it's safer for my devices to high-level disinfect them over the long term, and it is to sterilize them, even though the margin of safety that Tamara was calling out there, we all know that the margin of safety is different from a sterilized device than it is from a high-level disinfectant device. So how do you kind of answer that concern or that question today when folks are like, yeah, but is this the best for my device, the life of the device?
Right. Well, what we know right now is that the scopes that are specifically made for terminal sterilization, like the ones that Tamara mentioned with the half moon on them, are made specifically to withstand 100, 200 cycles in STERRAD. So that has been worked out with the MDM in partnering with us to make sure that the lifespan of these scopes are durable and are functional within their lifetime. But as you said before, gastroscopes, duodenoscopes, enteroscopes, colonoscopes, those are only high-level disinfected at this point, but there is a want and a need for those to be sterilized as well. And that's certainly something that ASP is working on. I don't know, Tamara, if we want to talk about it during this podcast, but we have introduced an Ultra GI cycle that will be able to sterilize these more complicated GI scopes. So I'm happy to announce that.
Absolutely.
Mm-hmm.
Absolutely. That is our exciting news, is coming into the new sterilization era for scopes that are typically high-level disinfected. What is that workflow pattern going to look like? What changes? What department is it going to fall on if there is a change? We look at 3 different models that we're working on currently, as a centralized model in GI only, a decentralized model where GI starts the process and then sends it down to SPD to be completed, and then a centralized process outside of GI, i.e. in the SPD. I was just at a facility in Alabama yesterday that they are centralized in SPD for the entire facility. So when we think about that workflow, they're already used to processing GI scopes, making sure that they're dried properly, and then they're sent back up for hanging in the scope cabinets ready for the next patient use. But what are those extra steps, or what is it going to look like when we start talking about, hey, okay, we've made it through steps 1 through 10, and now we got to change because we got to shift to sterilization and what requirements need to be done for it to go into a STERRAD, low temperature sterilizer, versus high level disinfection, where we know it's a wet environment and that's okay. We know STERRAD and water aren't best friends. So we've got to make sure that everybody, especially if it's in a centralized in GI, that they understand what bone dry really does mean before something goes in the STERRAD.
Yeah, I think that's an interesting point in the context of the workflow conversations that we were just talking about. Is if this volume is going through sterile processing, they're much more comfortable and familiar with that next step into the sterilization cycle that you mentioned, just with the dryness concerns, packaging and whatnot. And they would be typically in the endo suite, even though there's sterile devices many times coming back into endoscopy from sterile processing with the accessories and whatnot. And so it's not that they're completely unfamiliar with what that looks like, but there's a level of change in the training, and then perhaps again in the workflow design layout, but definitely in the equipment that's being used, obviously. Can you speak to, so I know, the big announcement is, hey, now we're going to have some capabilities to bring this into that sterilization conversation. How does that interface, Tamara, with the AER conversation again? Because the other big question and concern around all this is, hey, either way, this thing's got to get clean. If you're HLD or if you're sterilizing it, that's great. That's the cycle. But if you're putting dirty devices into either one of those, it's not going to be pretty. So can you kind of walk us through those implications here?
That is a great scenario. As I always think of, GI is my love. So you always think if you've got AERs in that department, or ECRs as we call it for our Evotech platform. But I think back years ago that we were manually hand washing our scopes. We were doing the bedside pre-cleaning, going to the reprocessing area, and everything was done manually. And that was even before Scope Buddies and any other accessory little pumps that helped us standardize those flushes with enzymatic and then water and then air. So when I think of where we were, and that was in the 90s, I can't even imagine where it was, when we first started doing GI scopes years ago, of what they did. Probably just wipe down the outside, right? So something we probably don't even want to think about from a visual perspective. But when I think about where we were with AERs, we've moved into the ECRs. As Khoi said, he was very, very engaged and influencing in the process of getting our cleaning claim, which was the first ever. So we had to establish what is clean. And that's where Corey Ofsted did her study and said, Dr. Michelle Alpha, what does clean look like? Because we don't have a definition for what is clean. We know it's not 10 to the minus 6, like a sterility assurance level of 1 in a million, but what is HLD in a clean environment? What does that look like as far as residual bacteria? So when she started looking and coming up with those studies, that's where we compared Evotech to me or someone else standing at the sink going through all of those steps. And when we came up with the ECR, the endoscopic cleaner and reprocessor, that's where, okay, I don't feel good today and I'm a technician, but I'm going to clean this scope, but I'm not doing it to my best ability. Now I've got that automated system that's going to repeat everything I did or did not do correctly at the sink. That's the beauty of having that insurance policy, if you will, for I know that it's going to get done. It's a redundancy. And we know redundancy, again, is going to reduce that microbial load. So as we continue to move from AERs, ECRs, and now into, okay, now we want a sterile scope. What does that look like? Can we even sterilize something that's 6 to 9 feet long? Can we guarantee that those internal lumens are cleaned properly? Because if you look at that change in reprocessing and that standard is, are we going to high level disinfect and then send it for sterilization? Or are we going to manually clean and then prep it for sterilization so that it's not going through the HLD part of the process? And that's where we'll rely on the IFUs from the devices as they come to market to see what that is going to look like. And we're certainly not going to tell anybody that you can't high level disinfect. That's going to be, facility by facility for their preference. But that, again, you've got to think about, what is that doing to the scope? Well, now we're high level disinfecting and we're going to sterilize each of these scopes. But we also know that they're already sending them down for ethylene oxide, which is very, very harsh on the scopes. So they're already used to ERCP scopes, either going out for repair a lot sooner or going out for that surveillance to make sure that everything's still intact. So they're going to already be used to that from an ETO perspective. Now just shifting over to low temp, I think they'll see that extended out a few more cycles than what ETO recommendation was.
So obviously we've covered a lot of ground in this interview. We only got a couple of moments here left, but I want to let you both maybe set the stage for what else needs to happen or is happening maybe in the industry today that's impacting what we've been talking about, right? So there's collaboration going on with the MDMs. There's collaboration obviously going on across the industry from the research standpoint, the best practice, the workflow standpoint from the clinicians who are going to have to change their process potentially. And then there's all this innovation happening in between. So you got the medical device manufacturers on one end, you got the equipment manufacturers, you got the chemistry manufacturers, you got a lot of players in there, even for the accessories like you mentioned with the brushes. A lot of different innovators in here trying to help to solve this process. But because of that, there are a lot of shifts and there's a lot of changes happening even right now in 2024 and 2025. So Khoi, what else would you say is out there that still needs to be fixed or that still has the attention of these groups to solve?
Right. I think it's just being the first is always the hardest, right? Because it takes a lot of time. It takes a lot of money. So, we've reached out to our partners, other MDMs, to say, hey, we're trying to develop this steroid cycle that can sterilize your endoscopes. And, now we have a cycle out there. So I think my message to them is like, come join us.
Okay.
At the end of the day, we want to make, these endoscopes sterilizable. It's better for our customers, those people who are so vulnerable, and also for our customers in SPD and those who work in the hospitals as well, to help streamline their processes as well. So
I love that.
Come join us.
Come join us. Be bold. Be brave.
Yes.
All right.
Exactly.
So that's Khoi's takeaway. Tamara, what else? What else would you say is left out there to do?
Yeah, and just wrapping it up from a clinical and an educational perspective is we know that there are so many different standards and guidelines, recommendations, what's required, what's recommended. And then we've got the additional TIRs that are coming out that are looking at water quality, monitoring bioburden. What is that going to look like? So now we're adding 2 more things to think about. I'm going to check how my cleaning was done, and then I'm going to check how's my water that is I'm doing my cleaning in. And if you find that you've got to be prepared to address whatever it is that you find. So if you find you've got water bugs in your water, then you need to have a solution for that. And I know there's so many different discussions going on now with water, soft water. We've required soft water from our perspective in the Evotech since it came out in 2007 for very good reasons. ASP is an innovative company that stays ahead of the curve, and that's exactly where we were with the Evotech of requiring hard water. While we got beat up by some folks of, oh, we don't require hard water, but they do, that's okay, because again, we were elevating that standard, knowing that that was the best outcome available for our patients at the end. So that's what we're here for. We want to make sure that we are providing the highest margin of safety. When I go in, or any of us go in as a patient, we want propofol, right? We want a scope that's been cleaned properly. And now if I can get a sterilized scope, heck yeah, I'm in.
Right. Yeah. So just want to clarify. So the device that you're referencing requires hard or soft water for working? Just
soft water.
Okay, soft water. Okay,
so you're adding the water softener to make sure those hard water particles are not an issue.
I mean, that's one example. Like to your point, the new water standard 108 that just came out here this past year. Like that's one of the shifting tides in the industry that's having so many implications across the board. And right down the center of this scope reprocessing conversation, because we're using water every single day on these devices, and not all water is created equal, as we're learning from the standards and the regulatory side of this. Great conversation, guys. We're going to have your contact information in the show notes here. If anybody else has any questions they want to throw off you, because we just scratched the surface here in a very complex, quickly moving part of the industry. But I think we did a terrific job outlining what some of those implications are for the shifts that's happening, what kind of innovation is coming down the pipeline. Obviously, the big news around the sterilization piece for some of these devices that we haven't had solutions for before. And I really like, Khoi, your call to action and saying, hey, it's hard to be out front. It's hard to be the leader because you look around. Sometimes there's not that many people behind you, but eventually you go far enough and everyone starts to say, okay, well, if they're going, I'm going with them. Exactly. So really, really cool to hear both of your stories. Really appreciate y'all's time today.
Thank you, Hank.
Thank you.
Pleasure to be here.
All right. Well, that was Inside the Idea, endoscope design and functionality in the context of reprocessing. You're listening to a 6-part series. It's called Safe and Sterile Endoscopes, sponsored by ASP on the Beyond Clean podcast network. We've got more episodes in this series yet to come, so hang with us. Make sure to subscribe to Beyond Clean. Check out these experts. Make sure to get connected with them. And like we tell you each and every week here at Beyond Clean, keep fighting dirt.